There's three main causes for infertility. One is a tubal factor problem, so blocked tubes, tubal infections, endometriosis. The other thing would be a male factor. 40% of all infertility is male factor. And then there's also ovulation disorders. And many of you know polycystic ovary disease, chronic anovulation, decreased ovarian reserve. We'll talk about some of these things. At least 40 to 50% of patient couples will have mixed problems. They'll have part male factor, maybe part tubal, part male, part ovulatory. So one of the main things to do is to make sure that a good workup has been done on these entities.
So when we start to look at the basic infertility evaluation, there are some simple things that everybody should have done. You know, the first two areas are really kind of assessing that ovulation issue. And so we tell patients, if you haven't really been tracking your ovulation, or if your cycles are nice and regular, we want to know, am I really ovulating? There's some simple things to do. People may have heard of basal body temperatures. That's a pretty simple thing that you can do. Not terribly sensitive. A better way to track ovulation are the ovulation predictor kits that you see. Has anybody here done ovulation predictor kits? Few people have. You find these kits in the area where they sell, you know, the urine pregnancy test kits, and it's a way of looking for that surge of that hormone LH that happens prior to ovulation. And so those kits are actually, you know, fairly sensitive. The other thing you can do is we can do progesterone levels. After you ovulate, the follicle that holds the egg, that releases the egg, produces a hormone progesterone. And so when you have that test, if it's elevated about day 21 or so of the cycle, that's confirmation that you've ovulated for that cycle. So those are some simple things that can be done. Assessment of an FSH level. On day 2 or 3 of your cycle, we often draw an FSH level. It's a blood test, and the FSH is a hormone that is secreted that stimulates your ovary. It stands for follicle stimulating hormone, and so that's exactly what it does. It stimulates the follicle in the ovary to grow, to mature, so that it has a mature egg inside. If early on in the cycle, on day 2 or 3, we draw that blood test and that level is elevated, that's a poor reproductive indicator. And so for patients that are over 35, we often draw a baseline. If you have regular cycles and you're under 35, it's not a test that we draw across the board on everybody. So if you've had some evaluation and haven't had that done, it's not necessarily something you should have had done. So we look at that individually and see if it's important to have that done.
What we want to look at is what is the best case or best practice model for a given patient. And that takes a lot of components. And that's where medicine is individualized. I mean, you have to take into account what is the patient's age, how long they've been trying to get pregnant, what are the major factors. So I give you an example here. Here's a female that's less than 32. That's good. The younger you are, the more likely you're going to be successful, all things being equal. Duration of infertility, less than 2 years, not bad. Severity of individual factors. If someone comes in and says, I have stage 4, very severe endometriosis, I've had 4 or 5 surgeries, I've had one of my ovaries removed, that's obviously a different person than someone that doesn't have those conditions. So we try to look at all the factors and then align the treatment to a risk category and say what is going to give them the best success rate. Now I could use a lower tech procedure to try and assess a person who has quite a few risks, and it could be successful, but in the main it's going to have a lower yield. And so that's where we talk to couples and see, well, what do you want to do? And show them statistics, and they can make decisions.